We are here today to collectively discuss, learn, and implement a powerful theme: collaborative learning for coordinating action, policy and practice for resilient health systems. These are not just words, they're a call to action to move beyond discussions, beyond reports and white papers into the realm of action. Because resilience isn't an abstract concept, it's a lived reality. Or, in absence of it, a brutal lesson that we all faced for almost 2 years before we actually started the GLC4HSR. Good morning, everybody, and it's a privilege to stand before you today at the third annual conclave of the Global Learning Collaborative for Health Systems Resilience. You will see GLC4HSR everywhere, and that's why we know that we are here to bring better into the world as we go forward. This gathering has grown not just in size, but in depth, in its reach and impact. And that is because of all of you. And what brings us together here is our common goal to build resilient health systems. In the past few years, we have made it painfully clear that the health systems cannot afford to be reactive. The COVID-19 pandemic, climate induced health crisis, conflict driven disruptions, economic shocks have tested our collective ability to respond. And some have withstood the pressure better than the others. Many buckled under the weight of these compounded crises. The lesson is clear. Resilience cannot be an afterthought. It must be designed into the very foundation of our systems. We've seen the fractures in our health systems and felt the weight of their failures and witnessed the profound difference that preparedness and coordination and agility can make. But the truth is that resilience does not happen in isolation. It is built deliberately, collectively, and persistently. That is why today's theme is so relevant. Policies must not be informed by the best evidence, but be feasible, scalable, and context specific. The conversations we have here today, spanning policy discussions, research showcase, expert panels, and case studies, are not just for academic curiosity, they are the blueprints for change. Over the course of this conclave, we will engage with policymakers, industry leaders, academic experts, healthcare practitioners, philanthropists, development partners, and civil society. A truly cross-sectional coalition that has the power to make this resilience more than just a response by the way of being. So let us listen. Let us challenge the ideas. Let us bridge that gap between research and reality, between intention and implementation, between learning and leadership. The work we do here matters, not just for the systems we serve, but for the people within them. With this, I welcome you all to the GLC4HSR 2025 conclave. Take a pause for a minute. The conclave kit, if you can put that up, please. Please scan this and you would have all that you need to know about the conclave. Again, being environmentally conscious so that we avoid paper and more. Such learning cannot happen without special acknowledgement to all those people who have come to speak over here, who've left busy days and schedules, to our co-hosts, Access Health International, Tata Institute of Genomics and Society, National Center for Biological Sciences, in order, and our partners in progress, APSI, USP, AHIN, Global Journal of Medicine and Public Health, the George Institute for Global Health, CESTI, Health Systems Global, CDRI, Asia Pacific Cardiovascular Disease Alliance, and AWS. With this, I request Dr. Reddy to please come and share his welcome address. Dr. Reddy is the Chief Executive Officer of Access Health International, and he's a champion of accessible and affordable healthcare.
Yeah, this is the third edition of the Global Learning Collaborative. The first edition was held in Delhi. I articulated how we intend to evolve over a long term. It was not just designed for a short term. We said we will evolve self-organizing, self-governing, and self-sustaining around the common purpose of all the members who are part of the GLC. So the purpose remains same. It's only health of the people, health of the planet, health of the animals. So the purpose remaining same, the GLC has been evolving around an idea of a collaborative learning so that we come up with solutions for the problems that we have. And each one of us who are part of this learning journey can take these learnings and put into our own actions. The intent is building that culture of learning, the pleasure of learning, but more importantly, translating that learning into actions. In fact, Access Health as its secretariat, we immensely benefited because we learned from the experts participating in this alliance, not only learning in 40 projects we are doing across Asia, we are putting into actions whatever learnings that happened here towards building the resilient health systems. So it grew to more than 100 members now as a part of this alliance, more than 30 to 40 countries representing this alliance. In addition to the formal membership of the GLC, also partnering. I mean, it is slowly evolving as a platform, kind of a network of networks based on each thematic area, which encompasses the health systems. So we have a network of the Asia Pacific Action Alliance for Human Resource for Health, which is again a 52-member nation alliance, which focuses on the human resource aspect of the health systems in terms of the resilience. Then we also have the Asia Pacific EHIN, that is Health Informatics Network, again, which is looking at the evolving digital transformation of health systems and what precautions, what oversight, while everybody knows the disruptive and the most powerful impact of these technologies in transforming and the leapfrogging the health systems. But at the same time, we have to caution ourselves that there is also flip side for some of these transformation. So AHN, in fact, again, it has many member nations as a part of its network. And the alliance has been guiding some of the nations in their own digital health transformative journey. Similarly, there are new alliances in terms of the Community of Practice on the Health Human Resource for Alliance by George Institute, which has been doing this work for the last 3-4 years and joining hands with the GLC and the Access Health to actually amplify some of these things. We also partner with the WHO CRO, the Primary Healthcare Forum, because we are also looking at what are the resilient models of healthcare which are integrated, which ensure continuity of care, which meets all the health needs of the people from promotion to palliation. So what's happening is the GLC as a platform is able to actually, I used to give the description of the river flowing to the ocean, and this branches on to each rivulet of each problem of the health system, whether it is at a community level or whether it is at a human resource level. So this is one of the evolution of the GLC over the last 3 years. We had great learnings in the last 3 years in terms of basic understanding. I mean, it started with in the first year, the very understanding, clear understanding of what do we mean by resilience in the context of health systems. Health systems is not like the elasticity of the physics, because resilience was a property applied to elasticity. But translating into a society, human society, then you need to have a different conceptual understanding what exactly you mean by resilience of a health system. So that it took almost 1 year for the members to deliberate and then come up with some clarity in terms of the resilience. And also there was a clear understanding that the resilience cannot be separated out from the existing focus areas of health system strengthening and health security. They are a continuum. The strengthening, security, and resilience are continuum, and they are not in isolation. Again, the conceptual understanding that the human health is not in isolation, it is interconnected and interdependent on the plant health and the planet health. So that means the One Health concept, I think it's accepted now globally as part of the health systems. But we are still struggling. How do you actually operationalize this conceptual understanding of One Health? The challenge is not simple. How do you actually bring together all these systems of animal sciences, the plant sciences, and the planet sciences, and then act as one group in terms of One Health concept? So these deliberations actually to bring out that clarity in each of these evolving hypotheses. And also we learned that health does not depend on health systems. In fact, 2/3 of the health status depends upon non-health determinants. So that rose, actually, the WHO gave the concept of that Ministry of Health is not the only one. It has to be the whole of government, whole of society, and whole of systems approach. Again, I think this is the conceptual framework which we still are yet to operationalize in practice. Everybody agrees this conceptual framework, but we haven't into practice. The other key learning during these 3 years was the importance of the people, because we say people-centered health systems, but we don't give importance to the people's voice, their health needs, their representation, their connectedness to the health systems, how actually their voice is taken to the policy making. So that is where, in fact, one of the prime session in this conclave is to deliberate on the community level actions to make community itself resilient, community itself taking care of its own health needs, a community itself offering solutions for their health problems. So the co-creation. So the community empowerment and engagement is a powerful learning area for all of us, because we were focusing only on the 6 building blocks of the health systems to the exclusion of what community role can be played. So that is another, I think, theme that emerged in the last 3 years. In addition to the what we started as a pandemic preparedness and the prevention and response systems, actually evolved into multiple health threats. There is a polycrisis. The world is amidst the polycrisis. It's not hypothetical. So it's a pandemics, it's climate change, it's conflicts, it's mass displacements, it's financial, economic crisis, and we are living it with the recent change in the governance systems across the architecture, global architecture. So there is a fresh crisis, especially the Africa is facing sudden withdrawal of the life support systems. So when you suddenly withdraw life support systems in an intensive care unit, that means you are allowing the patient to die. So these are the crises, how as a together, people interested in this purpose, we can deliberate in the next 2 days. And then, in fact, some of the learnings happened as a pre-conclave. In Cairo, there were 2 sessions on supply chain resilience as well as the resilience in the context of conflicts and the mass displacements. I think some of those learnings also will be presented during this conclave. So I think we at least I personally have been thoroughly enjoying this learning from so many experts, so many practitioners, so many researchers, different perspectives, because otherwise we live in silos. I, as a clinician, only look at personal health. I may not look at population health. So, but I started looking at population health in addition to being a clinician. So similarly, a researcher may look at how is research can contribute, like Rakesh representing the ticks. How is genomic environmental surveillance can be put into the actual surveillance model, which is future ready. So with these few comments and a warm welcome to all of you, hope you will enjoy the next 2 days of free learning and enjoyable learning. The thing is, it is like these insights are like infecting with a virus, a good virus. so that it multiplies in all our brains, and some of it actually translate into good actions. So with this desire and wish, I thank you again for coming over here. Over to you, Ma.
Thank you, Dr. Reddy, for setting the context for the next 2 days. We have now with us people who have lived experiences and who are going to share them with us. Each of their special addresses this morning is like a context that you can't take out of a textbook, because they are life's experiences that they will bring to us as we invite them onto the stage. Our first, we have all of you as I speak. Mr. Siddharth Sharma, the CEO of Tata Trust. Mr. Sharma was a civil servant at the Presidential Office for more than 2 decades, starting his career with the Government of India, and now leads one of the largest philanthropic organizations, the Tata Trust. Thank you so much. Professor Mala Rao, the Director of Ethnicity and Health Unit, Department of Primary Care and Public Health at the Imperial College London. Her career spans the workforce development of universal healthcare, and she remains an influential force at the intersection of race, gender, health, and climate. Thank you, ma'am. Dr. Upadi Siri Sinuk, Deputy General Secretary General, National Health Security Office, Government of Thailand. Unfortunately, couldn't travel here in person because of the visa issues. And that's what we have suddenly started facing, which we never faced in our first 2 conclaves. Dr. Upadi, thank you for joining us online. Mr. Manoj Jilani, Director, Health Systems Development, WHO Regional Office, Southeast Asia, New Delhi, and a former member of the Indian Administrative Service with his experience in health policy. I now request Mr. Sharma to please come and give his special address. Dr. Reddy, I thought you were going to be here.
Good morning, everyone. And on a lighter note and on a more personal note, I think I need to develop my own resilience. I landed in Delhi yesterday night, and my nose is already packed up. I think it has something to do with the AQI levels, though I'm told they are much better than what they are between October to February. Also, it's very, very nice for me to see TIGS represented here, because the Tata Institute of Genetics and Society was the brainchild of the late Ratan Tata, and they are doing some fabulous work. I happen to sit on their board, so I'm happy to see Rakesh here, and the fact that they will be sharing some of their experiences. It is a delight to be addressing this audience today. I'd like to extend my sincere gratitude to the Global Learning Collaborative for this convening. And when we talk about resilience of healthcare systems, it's much more than a strategy. It is an imperative that ensures that no individual is left vulnerable, regardless of their socioeconomic status, their health conditions, or the geography in which they reside. We had Dr. Reddy talking about a polycrisis. There are a number of public health concerns ranging today from infectious disease outbreaks, sometimes in the form of pandemics, to climate-induced adverse health effects, to a sharp rise in India's NCD burden. And in that context, all healthcare systems that we look at, the architecture that we look at, must be adaptive, it must be robust, responsive, and in the context, it must be rooted in the context of our country's growing population and our evolving needs. This resilience can be tested both by a sudden crisis like we saw in COVID and shocks due to climate change and disasters, and also by chronic stressors, which are deep-seated challenges that weaken health systems over time. These stressors span across geographic inaccessibility. Many people in remote and rural regions of this country have to travel dozens of kilometers, if not hundreds of kilometers, to reach the nearest health center. Workforce shortages, particularly of trained healthcare specialists in rural areas. Inadequate infrastructure, such as inadequate investment in primary healthcare systems, fragmented supply chains, and financial constraints. These issues of low capabilities, access, and affordability make resilience building an urgent necessity to address the challenges that face us. Climate change, as we all know, is posing one of the biggest threats to our health systems. And we must extend specific support to India's population, that part of the population which is most climate vulnerable and which is absolutely susceptible to health risks associated with heat waves, floods, and chronic stress of air pollution. In regions with limited access to healthcare, individuals often underreport illness. This is not because they are healthier, but because they are either not diagnosed or lack the means or the awareness to seek treatment, or are simply very stoic about their situation. This, from a public health policy perspective, calls for more robust surveillance and monitoring mechanisms with a focus on serving those in underserved areas and those who are most vulnerable. When working towards building truly resilient health systems, we should ask ourselves what the architecture should look like. It should be prepared, responsive, and adaptable, a system that is quick to identify, understand, and address crises or emergency threats, is able to scale up services quickly in scenarios of great demand, and to repurpose existing systems equally quickly. In that context, we, as I mentioned earlier, and I think this is something every healthcare professional or public policy expert knows, that we have to strengthen our primary healthcare systems. That is an individual's first point of entry into the care system, and as much as 80% of healthcare conditions can be addressed at this stage by a physician and or community healthcare worker in a PHC. I was just having a conversation, I think, in a country like India where we have 1.4 billion people and growing. We can keep creating as many tertiary institutions as we want. The scale is such that it is really not going to have an impact. And therefore, unless there are investments in primary and secondary healthcare, we are really not going to get anywhere. The system has to be built bottom up and not top down. If the foundation is not strong, there's no way that the building is going to withstand the stressors that I've been talking about. And I think that's one area of public policy where we really need to ramp up our investments and our spending. At Tata Trusts, we have always believed that healthcare extends beyond treating illnesses. It is about empowering people to lead fulfilling, dignified lives. For us, this has always meant ensuring care to all across urban and rural regions with a focus on the particularly underserved. I was reading a brilliant analysis, a report that has come out recently, which was talking about the stratification of the 140 crore Indians. Out of this, 10 crore Indians have per capita incomes which would qualify them to be high income. So the average per capita income for 10 crore Indians would be about $15,000 per annum. And this would place them at par with Mexico, this subset of the 140 crores. Then there's another 30 crores, which is what is referred to as the middle class. This is with a per capita income of roughly about $3,000 per annum. This would place you on par with country like Indonesia. So there are 10 crore Indians placed at par in terms of earning capability with Mexico. 330 crores who are placed at $3,000 per capita at par with Indonesia. And then you have the 100 crore Indians who have a per capita which is equivalent to sub-Saharan Africa. 100 out of 140 crore. And that is the area where we must be focusing on, and that is a priority for the Tata Trusts. We all know that one must get ready for war during peacetime or plan for crisis during stability. With our encountering the sudden onset of COVID-19, which was a black swan event, we all learned to proactively work towards building resilience to effectively respond to sudden emergencies. Our experience in identifying and implementing innovative solutions reflects this approach, particularly with a focus on process automation, upskilling general practitioners in specialized competencies, and with broader skill sets and beyond. Telemedicine specifically has been around for over 3 decades, and despite its proven effectiveness, was not scaled up. At Tata Trust, we launched multiple programs testing and leveraging the connectivity revolution starting in 2016. This involved leveraging the hub and spoke model with a hospital as the hub, such as in eastern and western Uttar Pradesh, and multiple spokes in a 100-kilometer radius. Efforts here included identifying and managing patients with NCDs in a systematic way. Then establishing single non-hospital hubs with multiple spokes, such as in Andhra Pradesh, with telemedicine services. Vijayawada, a city in AP, for instance, had a hub supporting 20 clinics for over 160 villages, which served a population of 2 million. This lets us help triage patients without serious or critical conditions who did not require hospitalization, while also managing patients with chronic diseases. In other regions like Telangana, we set up multiple hubs and spokes, connecting over 760 primary healthcare sectors to more than 40 district and teaching hospitals associated with the government. We were, through this, able to deliver over 200,000 specialist consultations to patients in their own village primary healthcare settings. Our tremendous experience with these innovations helped us later when we rapidly converted a central non-hospital hub and supported over 2,000 patients being treated in their homes because of overburdened government hospitals in Telangana. The necessity of digital consultations was eventually well established, and the government's issuance of telemedicine guidelines, as well as adopting e-Sanjeevani, were welcome moves. As one of India's oldest philanthropies, our decades of experience in advancing healthcare access showcase our clear commitment to this end. One of our most impactful interventions has been the decentralized cancer care model, which we have adopted in Assam. We recognize that 70% of cancer cases in India are detected in advanced stages, often because of a lack of or delayed screenings and access to treatment. As a response, we developed a hub and spoke model to bring cancer care closer to communities. So when I was speaking about the Assam cancer care model, we are delivering 17 state-of-the-art cancer care hospitals, decentralized, across the state of Assam. And this involves that anyone will have access to a high-quality cancer care facility within 150 kilometers of where they reside. There's Apex Center, which is the State Cancer Institute at Guwahati, and then there are decentralized centers across the state of Assam, and this has worked extremely well. That has been recommended by the Parliamentary Committee on Health, the Standing Committee on Health, to be replicated across India. A lot of governments are looking at how to implement this across their geographies, whether it is the government of UP, whether it is the government of Maharashtra and other areas. But supplementing that, again, I think as we need to realize that if we are able to diagnose cancer at stage 1, then the longevity is far higher. The mortality rates are far lower as doing it at stage 3 or stage 4. So a major part of our effort, apart from creating these high-quality cancer centers, has been on public outreach activities. I was speaking to the finance minister of Jharkhand recently, who had called on me in Bombay, and we are ensuring that we ramp up. The effort is to ramp up healthcare screenings and outreach activities from 3 districts in Jharkhand to the entire 24 districts in Jharkhand. And I think it's very important that we realize, we do away with the stigmas, the fear, and we reach out to the general population, make them undergo testing at primary healthcare centers, etc., so that the burden of the cancer disease is far lower than what it is today. We intend to continue working closely with the government as well as other partners across the private and public sectors, because making India's healthcare system more robust requires concerted efforts that we need to bring about sooner than later. In this journey, we continue staying aligned with the nation's broader objectives, particularly so we stay on track to achieve the critical sustainable development goals. I think as I end, there's another pillar that I'd like to stress on, and that goes much beyond services or architecture or systems and processes, and that is people's mindsets. Creating trust in the system and effectively leading educational efforts, supported by strong social and behavior change communication and other ways to engage with local communities, is vital, because healthcare systems don't help when people are not comfortable utilizing them. One major challenge to healthcare is non-adherence to medicine. The WHO summed it up neatly. If everyone who was prescribed medicines took them as intended, the impact on health overall would be far bigger than any improvement in specific medical treatments. Similarly, awareness involves addressing specific biases and tackling social norms, which particularly arise when we are dealing with topics surrounded by social stigma, including menstrual health and hygiene and breast cancer. I would just like to end by saying that the gains made by countries across the world in building resilient systems in response to the COVID-19 pandemic can be quickly lost if we are not vigilant. We should not forget the important lessons we have learned, nor neglect the reforms that are still underway. Together, as a joint collaborative, as a joint effort, let us continue to spearhead efforts along our collective journeys to advancing and investing in healthcare systems that are equitable, resilient, and inclusive. Thank you.
Tata Trusts and the Tatas, I personally go back as a child with them. And the change that they have made always is phenomenal. So for us to be a part of this extended family, Professor Sharma, it's a pleasure to have had you come and address us as one of our opening speeches. Dr. Mala Rao and I go back from the time when she was in PHFI, and I was a young girl learning how to actually navigate healthcare. Ma'am, it is an honor to have you come and speak and address us. Thank you. And while I have Mala ma'am coming up, we are indeed pleased to welcome Dr. El Sobki and the Ambassador of Egypt, Kamal Galal. Thank you for joining us this morning.
Could I have my slides up, please?
Are you okay?
There we are.
Just give me a minute.
Okay.
Give you an additional height to see well.
Ooh.
That makes
Can
it
you see me
easier.
now?
That makes it easier.
Perfect. Yeah, thank you. Could you put my slides up, please? I know you have them. Right. Well, Dr. Krishna Reddy, Dr. Omar, esteemed colleagues and friends, I'm honored to be invited to contribute to this inaugural session on building health systems resilience in a time of polycrisis. You asked me, Dr. Reddy, to talk about an academic perspective, and that is precisely what I will do. I am delighted to be given this opportunity to share some thoughts in my capacity as an academic. Next slide, please. The United Nations Sustainable Development Goals 2024 report highlights that we live in a time of choice and consequence. This stocktake at this stage, when we have 5 years left to reach the deadline, presents a rather bleak picture. Only 17% of the SDG targets are on track. Nearly half are showing minimal or moderate progress, and progress on over 1/3 has stalled or even regressed. The COVID-19 pandemic has undone nearly a decade of progress on life expectancy and has profoundly affected social, political, economic, environmental, and health systems at household, community, national, regional, and global levels. Furthermore, the frequency of emerging infectious disease threats like COVID-19 is expected to increase. New and protracted global conflicts are affecting millions, with refugees and forcibly displaced populations at the highest level on record and appalling numbers of civilian casualties. Climate change is worsening. And then we have the new and potentially existential threats, such as misuse of AI and biological and other forms of technology. And now to all this, we must now add a turbulent geopolitical landscape, which is redefining where old collaborations may cease and new partnerships must begin rapidly. The cumulative result is that low-income countries bear the greatest brunt of these multiple and reinforcing impacts. Next slide, please. I'm aware that there's a whole session on the climate crisis, but given that this is the greatest threat to health systems resilience, it merits a brief mention in the context of polycrisis. The planetary ecosystem is in rapidly increasing peril. A key observation of the Copernicus Climate Change Service of the European Union, which provides authoritative global climate data, was the big difference between the temperatures of the last 13 months and previous temperature records, leading to the director of the service stating that we are now in uncharted territory and new records likely to be set in future months and years. Their most recent update was that 2024 was the warmest year on record and the first to exceed 1.5 degrees C above pre-industrial levels for the annual global average temperature. Now, scientists, as we know, are in general uncompromisingly objective and not given to emotion. Scientists who work with the International Panel for Climate Change, the IPCC, to review the climate research and publish the evidence which guides global action, participated in a survey conducted by the UK's Guardian newspaper. They reported feeling terrified. These were words they used. Feeling hopeless, feeling broken, feeling that we live in the age of fools, worried about the future their children were inheriting. 77% of these scientists predicted that the global temperatures will reach at least 2.5 C above pre-industrial levels. 42% were convinced that it may top even 3 degrees C. Now, why am I telling you all this when there's a whole session to come yet? It's because all aspects of the climate crisis will continue to worsen, and that's going to worsen the polycrisis. But when faced with multiple and immediate challenges, such as health financing and infrastructure, health system resilience to climate change risks, dropping off the list of priorities. This is already happening in many countries. Besides, when even the science of climate change is being questioned, we must remain steadfast in our evidence-based strategies and listen to what our climate scientists are telling us. Next slide, please. So how are we to respond? A UNDP foresight brief entitled Polycrisis and Long-Term Thinking and published in 2022 urges the need for boldly reimagining the development agenda in a time of polycrisis. The term now commonly used to describe the multiple overlapping and interdependent crises resulting from the coexistence of simultaneous and interlinked global threats. And as Kwame and co-authors highlight in their 2024 paper, the term better reflects the increasing global complexity of interconnected impacts, the multiplicity, the simultaneity, the gravity of the threats they pose, their systemic knock-on consequences that deplete resilience across many dimensions, including health, and the transformed and systemic global responses that are required to resolve this. Next slide, please. So how are health systems to be strengthened in this context? Next slide, please. There are many guidance documents and reports that have been published on strengthening health systems resilience, including this latest guidance published by WHO last year. These reports define health systems resilience as systems that are able to anticipate, prevent, prepare for, absorb, and adapt in response to and recover from a wide variety of shocks and stressors, while continuing to deliver quality health services if needed, utilizing lessons from experiences within and outside their settings to continuously improve their capacities and performance in all contexts. These reports recommend time and time again that to achieve this resilience, health systems need to ensure that they're robust enough to deliver routine services in the first place, that they include resilience planning within all relevant health system components, including public health functions and services, and ensure that past lessons are recorded and acted on. But are these recommendations acted on? The answer is no. One very pertinent and recent example is a 5-year review of the UK's response to the COVID pandemic published only 2 days ago, which showed that the UK performed worse than many other developed nations despite spending more money on economic help. It has witnessed larger drops in life expectancy, more people too sick to work, and high levels of mental health problems in young people. And although there will be a range of factors to explain these variations, experts have concluded, you know what? That a key difference is the consistent underfunding of the National Health Service, the NHS, leaving it without much resilience to cope when the pandemic struck. Next slide, please. So what can academics and policymakers do together to build health systems resilience in a time of polycrisis? There is a need for better data and research evidence which addresses complexity at every level. As Kwame and colleagues highlight in their insightful paper on this, published evidence continues to be limited and inadequate and mainly comes from, for example, correlational studies, which can only investigate bidirectional interactions. There's also an unacceptable geographic imbalance with fewer studies focused on the global south, which is where the major burden of polycrisis is faced. That needs to change, and we in this room should do something about it. A greater range of research methods and integrated data is required. One suggestion is for applied systems thinking, grounded in complexity science, which can drive deep into complexity and enable tipping points, causal loops, and a diverse range of factors to be included in systems modeling. This may be new, but we are really going to have to give this our best shot. Participatory processes, others have mentioned it, which enable all stakeholders, including those the most deprived people in our communities, to contribute to the research and translate them into action are critically important. Academics and policymakers need to be more ambitious about their cross-disciplinary approach to evidence gathering and planning solutions. So, for example, social anthropologists and historians could inform health systems resilience research by investigating how different societies have reacted to crises in ancient times and what factors and socio-ecological interactions strengthened or destroy resilience in times of polycrisis. It's absolutely amazing how even ancient history has so much wisdom to offer us in this current age. Then let's consider hackathons. a new methodology which encourages diverse teams to come together to design, test, fail, and refine rapid solutions to healthcare challenges. Because perhaps our usual way of dealing with research questions in academia, which is to apply for a grant, do a piece of research in 5 years, and find some solutions, by which time, people have even forgotten, and policymakers have forgotten, they even asked us that question 5 years previously, may well have passed in this age of polycrisis. And all this requires academics to help develop new competencies in health leadership and governance, information, financing, workforce, service delivery, and infrastructure at every level. Next slide, please. So, this is my conclusion. A society grows great when old men plant trees in whose shade they shall never sit. This is a lovely quote I came across in the opening paragraph of the UNDP Polycrisis and Long-Term Thinking Foresight Brief. It powerfully summarizes our collective responsibility to put aside short-term interests and be bold and think long-term as we focus on how we overcome upheavals to secure the health and well-being of this and future generations of people and the planet. Thank you all so much for listening.
We had India, we had the academics, and now we have Thailand, who actually lead us to listen on many of the fronts that they have taken forward as part of their primary health care. So I have Dr. Upadi, who is here with us today online. We welcome you, Dr. Upadi, to please share your thoughts and how Thailand has worked towards making resilience happen. Thank you.
Sawadee ka. Hello, everybody. Okay. I would like to apologize for that cannot coming to the conclave. However, I like to join in every session if you can in like a online mode. So I start. Distinguished guests, colleague, and partner. It is an honor to join you at the third annual Global Learning Collaborative for Health System Resilient Conclave. I also thank the Global Learning Collaborative for Health System Resilient and Access Health International for bringing us together to discuss these crucial topics. This year's theme is collaborative learning to coordinated action, policy, and practice for resilient health system. Couldn't be more relevant as we navigate pandemic, climate change, economic uncertainty, and setback achieving universal health coverage. We must turn challenge into opportunities to strengthen health system resilience. Since achieving USC in Thailand in 2002, we have remained committed to its continuous development, ensuring essential healthcare for all people living in Thailand. However, maintain universal health coverage amid demographic shift, the advancement of high-cost healthcare technology, and emerging health threats require ongoing adaptation. So to being a resilient health system, we focus on three key pillars. One, strengthening primary health care. Second is empowering communities and ensuring financial sustainability. So I would like to go to the first pillar, strengthening primary health care. Primary health care is the foundation of Thailand health system. Decades of investment in primary healthcare infrastructure and workforce have ensured nationwide coverage. The proof variable during COVID-19, enabling an agile community-based response. So Thailand can pass it very, I think it's more easier than other countries. due to the our infrastructure. Technology and innovation have played a crucial role in expanding and enhancing primary healthcare services while ensuring seamless integration across public health insurance schemes. During COVID-19, various social and technological innovations were implemented to improve access to care, including partnership with pharmacies and private clinics, telemedicine and telehealth services, and home-based care. Additionally, technology-driven registration and verification systems allow individuals to use smart identification cards for instant access to services. This advancement lays the groundwork for the 30-baht treatment anywhere initiative, which enhance accessibility, reduce hospital overcrowding, and improve service efficiency. This initiative enhanced primary healthcare services by adding a new approach, particularly involving the private sector under the concept of Health Innovative Unit. This unit includes 7 key types, or in Thai we call 7 angels health facility, including community pharmacy, nursing clinic, dental clinic, physiotherapy clinic, medical clinic, medical technology clinic, and traditional Thai medicine clinic. So the people can access to all these innovative units for free of charge. As a result of ongoing efforts under the USC, there are now a total more than 13,000 health innovative units spread across the country. These units have received positive feedback from the public as they offer quality services with convenient and wasting time. This proximity to people homes not only reduce travel costs, but also help ease overcrowding in hospital. The key success of expanding services through this health innovative unit lie in developing service technology that enhance convenience and quality of the system. We have to integrate patient data across various healthcare services, health service unit, and setting appropriate reimbursed service fee along with an efficient reimbursed system to be the incentive for this private facility. They accept our rate. This may be the normal rate that in the society. The second pillar is about the empowering the communities. People participation and community involvement are vital in shaping Thailand's universal health coverage to meet people's needs. The people and community, they feel a sense of ownership of the national health security system. They think it's their system, so they have to protect the system because they join us involved in the driving the system, the universal health coverage at the beginning. Most of them do suffer from the catastrophic illness, so they join us since before 2002 that we start this universal health coverage. However, the system still continue to foster the community engagement through several mechanisms. For example, first, by law, the National Health Security Act, it mandates that we have the public representative people from the civil society as the committee in National Health Security Board and National Quality Control Board. So it means that another level of decision-making committee, we still have the seat for all the civil society and the representative from the public side. Second, maybe we saw also by law, we also set up the grievance mechanism under the Section 50 of the National Health Security Act, the establishment of independent complaint management center that's separate from the service provider. These are all responsible by the civil society. This center have critical roles in protecting the people's rights in accessing their needle care. And the last one maybe that I lay some example is about the local health security fund. That is financed by both National Health Security Fund in the national level and the local government in the local area. They serve this budget for the development of the community health system. This is achieved through joint decision-making by the government and the community, and all the local government can join. They are matching the fund to improve the quality of services in local level. As a result of such participation, people actively engage in their health system. They become partners in prevention, disease control, curative and rehabilitative services, as well as public health services. So this leads to the sustainability of the health system and the sustainability of the national health security also. The last pillar is about the ensuring financial sustainability. Thailand universal health coverage is primarily government funded, ensuring equity and financial protection to all. Household out-of-pocket health spending has dropped dramatically from 45% of current health expenditure in 1994 to just only 9% in 2021. However, rising healthcare costs and aging population and the burden of non-communicable disease pose challenges. To sustain financial viability, we focus on, for example, we focus on at the beginning, the benefit package listing, the process of determining benefits in health security system must have focusing on select only the cost-effective services that do not place a financial burden on the country budget. Maybe we also focusing more on the preventive more than the curative. We leverage digital health and community-based healthcare services to reduce the long-term cost. And other essential management is about the system efficiency enhancement. We try to reduce the price of everything that we can reduce. For example, we negotiate the price of medicine, equipment, or any essential services with the healthcare provider. We conduct the central procurement and central bargaining to help them reduce the cost also. So the challenges we face are not unique to Thailand. They are shared by many countries striving for USC now. Now, more than ever, we must learn from each other, share best practice, and collaborate on solutions that ensure health security, equity, and sustainability for all. So let us move from learning to action, build stronger partnership, and implement that policy that will make resilient a reality for millions worldwide. Thank you so much. สวัสดีค่ะ
Dr. Upadi, you are missed in person over here, but thank you for taking the time to be here online and give us your valuable insights. Dr. Manoj Jilani needs no introduction to this audience. He has been our steadfast supporter from day one, provided his guidance, and the team has been an extended part of Access Health and the GLC4HSR. Dr. Manoj, it is indeed a privilege to have you here and to support all that we do as we go forward very steadily on this journey. Thank you so much.
Thank you, Uma, for a very kind introduction. Honorable Dr. Ahmed, Dr. Sinosuk, Professor Mala Rao, my dear friend Dr. Reddy, all other esteemed friends and colleagues joining in person and virtually. Good morning. It's an honor to address this annual gathering of Global Learning Collaborative for Health Systems Resilience. I extend my sincere gratitude to the Access Health International team for inviting me to share my reflections and fostering a very close partnership with WHO as the collaborative has matured. I recall 3 years ago, the GLC was launched, and I've had the pleasure and privilege of participating in each of its annual conclave. The Access Health team and the philosophy underpinning this initiative has been central to the WHO Southeast Asia Regional PHC Forum for PHC-oriented health systems, our collective PHC Forum. Ladies and gentlemen, the COVID-19 pandemic, and particularly its devastating Delta wave, exposed significant gaps in the health systems worldwide. A crucial lesson from this crisis was that countries with PHC-oriented health systems, characterized by strong community engagement and trust, were better equipped to handle the unforeseen challenges. In 2021, reflecting on these lessons, the ministers of health in the Southeast Asia region of the WHO recognized once-in-a-century opportunity and an urgent imperative to strengthen PHC orientation of the health systems. Our gathering today reinforces this imperative. Progress towards UHC and health-related SDGs remains insufficient. 3 years after the pandemic, the collective memory of our shared struggle is unfortunately fading. Meanwhile, challenges rooted in the MDGs persist, and additional pressures from climate change, demographic shifts, epidemiological transitions, economic constraints, humanitarian crises, and rapid urbanization continue to strain health systems across societies. You're all aware the global health landscape is evolving very rapidly. In this context, the GLC, grounded in bottom-up learning and innovation across Asia, assumes even greater significance. The theme of this year's gathering, collaborative learning to collective action, is particularly relevant. In fact, it's very, very close to my heart. The no-do gap, it's been quite large. And I recall my days as a mission director NHM, where I used to really focus primarily on implementation. And I felt that the real challenge was not so much in terms of knowing what to do, but really ensuring what we know will really deliver positive health outcomes is actually implemented. Over the next 2 days, the GLC has thoughtfully organized discussions on building resilient and future-proof health systems through a PHC approach, focusing on health systems building blocks and digital technologies as key enablers. It's essential to emphasize that a well-functioning health system not only strengthens health security, but also advances UHC. A PHC-oriented health system reinforced by multi-sectoral coordination and community engagement. So our PHC really is 3 pillars. One is the multi-sectoral coordination, another is community empowerment and engagement, and first one is primary care and integrated public health function. That is what will drive both UHC and health system resilience. Allow me to highlight a few key points regarding the importance of investing in this 6 interconnected health system building blocks. And you were mentioning about the building blocks. And where are the people? So people are the center of all these building blocks. The WHO has come out with the 6 building blocks for health system. The first one, the leadership and governance. Countries with strong leadership and well-established mechanisms for cross-sectoral collaboration and community engagement, both at the national and subnational levels, were better positioned to mobilize the whole of government and whole of society response to the pandemic. Leadership at the head of the state level proved vital, and community trust fostered through effective governance was a crucial factor in risk communication and public compliance. However, during the initial phase of the pandemic, challenges emerged, including incoherent policies, duplication of efforts, and erosion of community trust. By further strengthening the governance and government stewardship, we can optimize resources, including through private sector engagement, for better health outcomes and pandemic preparedness. On the service delivery front, the pandemic, particularly during the Delta wave, exposed major gaps in chronic underinvestment in service delivery systems, insufficient health infrastructure, limited hospital beds, inadequate laboratory capacities, shortage of medical equipment, including ventilators and oxygen supplies, and an overstretched health workforce became glaringly evident. The unnecessary overcrowding of tertiary and secondary care facilities further underscored these weaknesses. In contrast, countries with strong primary healthcare systems, where health services are closer to the communities and integrated with public health functions, were able to mount a more effective response. Across the region of WHO Southeast Asia region, there are ongoing efforts to advance PHC-oriented health systems. A particularly promising area is the rapid expansion of digital technologies, offering opportunities to enhance equity, efficiency, accountability, and quality simultaneously. Even during the pandemic, we witnessed a leap in the use of digital technologies, including telemedicine, telediagnostics, and doorstep delivery of medical products. The continued evolution of artificial intelligence presents a transformative opportunity to future-proof our health systems. And I must use the word responsible AI, drawing on the threat that AI also poses. On the health workforce, strengthening health workforce has been a priority in our region, with a regional flagship initiative leading to a 70% increase in the availability of doctors, nurses, and midwives over the past decade. Looking ahead, it's imperative to further capacitate and support this diverse health workforce, focusing on delivering essential health services and public health functions and quality. At the recent 13th annual meeting of AAAH on Human Resources for Health in Lao PDR, the central theme was building a resilient health workforce and preparing for future public health emergencies. And the consensus was clear: competency and commitment are the foundation of a resilient health workforce, and they need to be the priority moving forward. On the medical products, including vaccines, technologies, therapeutics, the pandemic underscored vulnerabilities in global supply chains, leading to shortages in essential diagnostics, therapeutics, and medical devices. And countries with robust demand forecasting, procurement systems, quality assurance, and resilient supply chains were better positioned to ensure equitable distribution of medical products at affordable prices. Additionally, efforts to reduce foreign dependency, boost domestic production, and diversify supply bases must be strengthened. The unprecedented speed and scale of COVID-19 vaccine development, manufacturing, and distribution demonstrated what is possible. Now we're keeping a target of 100 days. However, it also highlighted stark inequalities in access and financing. Long-term investments and partnerships must be guided by principles of equity and solidarity. On the health information systems pillar, the pandemic reinforced the importance of timely, reliable data on health determinants, system performance, and health outcomes for effective decision-making. However, it also exposed fragmentation within the health information systems. Moving forward, strengthening routine health information systems, including surveillance capacities, and promoting evidence-based decision-making at all levels would be critical. Digital technologies can play a transformative role in integrating and improving the quality of health data through interoperable systems. On the health financing pillar, without adequate financing, health systems cannot function. Even before the pandemic, the annual financing gap for PHC for 67 LMICs was estimated at US $134 billion, rising to $371 billion by 2030. our region faces the dual challenge of low public health spending and correspondingly high out-of-pocket spending. The economic shocks of COVID-19, compounded by geopolitical crises, have exacerbated fiscal constraints. Nevertheless, increased domestic investments in health, including through pro-health taxation, are imperative. The pandemic proved that health security is fundamental to economic security. The cost of inaction far outweighs the cost of preparedness. As per the WHO World Bank estimates, just $1.30 per person globally, that's about 10 billion US dollars globally, could establish a robust pandemic prevention and response system, potentially preventing crises like COVID-19. In contrast, the pandemic resulted in a staggering 3.1% decline in global GDP between just 2019 and 2020, equivalent to roughly US $3 trillion. Digital health and responsible AI can be a great enabler in strengthening health systems by enhancing efficiency, accessibility, and responsiveness. By integrating these technologies, health systems can become more resilient, adaptive, and capable of delivering high quality care even in times of crisis. The road ahead is challenging, but building resilient health systems utilizing domestic resources is both necessary and achievable. However, success will require solidarity and synergy in all our actions. As I quote often in our conferences, coming together is a beginning, keeping together is progress, working together is success. We have come together, we are learning together, and now more than ever, it is time to work together to build stronger, more resilient, and more equitable health systems worldwide. Thank you so much.
Dr. Manoj, you actually summed up the entire conference in 10 minutes. And what we would like to take forward over the next day and a half as we speak is what you have set as the context this morning. We are looking forward to working together. And you know, we are strong partners wherever we do come together. And while I'm here, the GLC over the last 3 years has several chapters. We have chapters in Singapore, we have chapters in Indonesia, we have chapters in Bangladesh, we have chapters in India, and we have a state chapter in India in Telangana. And we are now looking forward, we have a chapter in Dubai, and we are now looking forward to the newest of the chapters, which is the MENA chapter. I am going to, while I leave you on stage, invite Dr. Ahmed El Sobki, Chairman of the Egyptian Healthcare Authority, who will be sharing key insights after the launch. He brings to us the Egyptian Universal Health Insurance experience, a model that exemplifies the power of policy innovation, strategic implementation, and long-term health system strengthening, and is the winner of the International Health Federation. I'm also going to request Dr. Hala, our regional director, to please join us as we... Where's Girish? I don't see Girish. Please join us on stage, Girish, for the MENA launch. We are really honored that the launch is going to be in the presence of Dr. El Sobki and the Ambassador of Egypt, Kamal Galal. So it is indeed a proud moment for us to join to this chapter and this collaborative. Yeah, I would like to have him on stage, please. Our friends from the MENA chapter do us proud. Would you want to stand up and be identified, please? Mariam, Shaza, Kaleem. Thank you for the official launch. And can we have our little video play? It's played? Oh, I didn't even see it. I request Dr. Subki to please come and share his address.
Thank you so much, Dr. Oma, for this kind introduction. And good morning, everyone. Namaste. This is in India. Your Excellency, Mr. Ambassador Kamil Galal, Ambassador of Egypt to India, Professor Dr. Krishna Reddy, CEO of Access Health International, Your Excellency, Dr. Hala Zayed, Regional Director of Access Health International in MENA region and the former Egyptian Minister of Health and Population, esteemed colleagues, the Egyptian delegation representing Egyptian Health Authority, Unified Procurement Authority, and Academia International, esteemed global directors of Access Health International, ladies and gentlemen. Allow me first of all to thank Access Health International for inviting me as guest speaker in the Global Learning Collaborative for Health System Resilience annual conclave this year. I'd like also to highlight and appreciate the great efforts of Access Health International as global think tank for strengthening health systems all over the world since founded in 2007 until now, through adopting comprehensive system-level approach to improve health access, delivery, and quality. In this regard, let me also congratulate the GLC for Health System Resilience, being an example of collaborative and innovative platform with more than 107 members from over 30 countries. This collaborative has fostered partnerships, shared knowledge, and developed transformative strategies to address the most pressing health challenges nowadays in the world. In Egypt, we reflected the core themes of the GLC for Health System Resilience. We have put health digital transformation as a priority to leverage technology to enhance service delivery in paperless environment. We have focused on building resilient infrastructure and empowering our healthcare workforce, as we believe that people are the background of any health system. With a strong political will and a clear vision of His Excellency President Abdel Fattah al-Sisi, who launched Universal Health Insurance Program in 2018, aiming to reform our health system toward sound governance and more resilience. We succeeded to achieve universal health coverage in 6 governorates out of 27 governorates in the first phase of the implementation of the program, and we are heading to extend the umbrella of universal health coverage to cover all the Egyptian population by 2030. Today, I'm extremely honored to announce the official launch of the MENA chapter of the Global Learning Collaborative for Health System Resilience, beginning with Egypt. This historic occasion makes a significant milestone in our collective journey toward a stronger, more adaptable health system in our region. Today, we in the MENA region take our place in the global network, bringing our unique perspectives, experiences, and innovations to the table. The launch of this MENA region chapter comes at very critical time as we navigate the regional economic and geopolitical challenges, from military conflicts to emerging health threats of displacement. We believe that this platform will allow us to, firstly, sharing best practice and lessons learned from regional perspective. Secondly, collaborating on innovative financing mechanisms to ensure sustainable health system financing. Thirdly, developing regional strategies for supply chain resilience, crucial for equitable access to medical supplies. And finally, enhancing knowledge exchange on surveillance system and collective preparedness. As we start together this journey, I call all stakeholders in the MENA region, policymakers, healthcare professionals, and academics to join us in this collective effort. Your insights and your experiences and your dedication are invaluable as we work together to build a health system that are not just resilient in times of crisis, but continuously adaptive and improving. Egypt Healthcare Authority is fully committed to fostering dialogue, driving innovation with the counterparts in the region to improve the health and well-being of our peoples. And before leaving the floor, I'd like to convoy greetings of His Excellency Professor Dr. Khaled Abdel Ghaffar, the Egyptian Deputy Prime Minister and the Minister of Health and Population, and his best wishes to have successful conclave. Finally, I look forward to our journey ahead as we strengthen health system resilience across the MENA region, leaving no one behind. Thank you. Shukriya.
We now have to take a momentous break, a little bit of a walk outside to get our GLC picture, which actually stands out each year as this collaborative grows. So if you walk out, you see the stairs, and we'll all walk there, get our picture, and come back here for the first session. Thank you.